Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. This week, we're back with Dr. Winston de Mello. We're talking about safety and effective treatments in reducing ICP following severe TBI. So, Winston, what's the clinical background of this? What is TBI and what are you going to be discussing about TBI this week?
I thought it would be a really good time, Aebhric, to sort of start looking at the evidence for treatments for severe TBI. And that would also apply to mild and moderate, don't get me wrong, but it's the severe TBI that really is a distracting injury for the majority of us, just like a major burn. And I just wanted to reassure our listeners that there are some basic principles they could follow when they look after their patients that will be evidence-based, but more importantly, not influence or the outcome in a deleterious way, and hopefully reduce morbidity and mortality. As you know, a forceful impact to the head can, we know, have a long-term effect on mental status and lead to neurobehavioral aspects. In the UK, for example, the football players in the 60s, 70s, they were heading leather balls, which were wet, often in the winter. Follow-ups of footballers over the years have found that they develop neurobehavioral deficits, are more likely to get Parkinson's, more likely to die early. So there is a resurgence of the importance of this subject of repeated concussion. Now, when we talk about a severe TBI, we're talking about a GCS of 8 or less. Fortunately, the majority of us won't have managed these kind of patients on a frequent basis because these are usually found in a neurocritical care ICU. But the majority of TBIs are mild, but we reckon about 20% worldwide would be regarded as severe. And the world incidence is about 70 over 100,000. So it occurs, but it's not very common. So besides the primary injuries to whatever caused the problem in the first place, there are several things that combine together to make a secondary harm and a secondary brain injury. And this is where we, in the absence of prevention of the brain injury in the first place, can actually reduce the morbidity and the mortality. Now, these injuries are either focal or diffuse. Now, if they're focal, they're more amenable to therapy. But if they're diffuse, like a diffuse axonal injury, the prognosis is very poor. But over a period of hours and days, the inflammatory process that occurs in the brain then makes it really complex. But also the messengers from these from the byproducts of brain inflammation then affect other organs. So these changes in brain injury cause an increase in volume of the intracerebral content. So brain, CSF, and blood, essentially. And if those volume goes up, then you have a rise in ICP, and then this leads to secondary brain injury. So the normal ICP is about 7 to 15 millimeters of mercury. But what is really surprising, if there is a sustained rise of ICP, this will lead to progressive cerebral ischemia, herniation, different kinds of syndromes, depending on where the focal injury is, and death. Therefore, it's important for the first responder to initiate early resuscitation and reduce cerebral oxygen demand, optimize perfusion of the brain, and limit second injury. Now, for all of us in the pre-hospital environment, we know this. It's been going on for 30, 40 years. But the Seattle International Severe Traumatic Brain Injury Consensus Conference, which is a big mouthful, in 2019, got all the experts together in the absence of any RCTs. This is the message I want to get to our listeners. There are no RCTs in severe TBI. So the next best thing is to get the consensus by Delphi approach and see what international experts have to say. And what they suggested, a bundle of care in 4 tiers, tier 0, 1, 2, 3. And from our pre-hospital environment, tier 0 is probably the most critical thing for us to achieve for our patients, because that tier does not require ICP measurements. Going back to the next question, which was actually what are the tiers? I just want to go through the tier 0, okay? Because this is the basics. This is what we expect our practitioners in pre-hospital to do, and it does not depend on having an ICP monitor, okay? Which is understandable. So, expected interventions, and I'll go through each, but I'll also say what is not and what is not applicable to pre-hospital care. Admission to ICU, well, no. Okay. Endotracheal intubation and mechanical ventilation, yes. Serial evaluations of neurological status and pupillary reactivity, i.e. GCS, possible. Elevate head of bed 30 to 45 degrees to allow venous drainage, possible. Analgesia to manage signs of pain, that's possible. Sedation to prevent agitation, fighting the ventilator, again, possible. Temperature management, keeping the core temperature below 38 degrees. That's possible by just basic approaches. We know that if you're being ventilated, your body becomes homeothermic anyway, but poikilothermic, I beg your pardon. So it's not an issue. And then the interventions are insertion of a central line. Consider anti-epileptic treatments for only a week if they've shown cerebral irritability. Maintain CPP above 60 millimeters of mercury. Maintain hemoglobin above 7. Avoid hyponatremia, optimize venous return, which means keeping the head in the midline, making sure the cervical collars are not too tight, and maintaining saturations, oxygen saturations above 94%. So that's tier 0. So that is really what I want the listeners to say. This is what you can do for a severe TBI without too much trouble, because you're not depending on high tech and you're not depending on ICP measurement.
Yeah, it seems like a paramedic can do pretty much everything on that one.
Yeah.
And monitor in situ.
Yeah.
So you said aggressive fluid increases ICP. How do we handle someone who is hypovolemic and has a TBI? Do we give fluids or no fluids?
Well, before I answer that, I would like to sort of just finish off the Seattle tier system of tier 1, tier 2, tier 3. Okay.
Sure.
So this is now like the more advanced stuff where there is even less evidence for anything we do, sadly. So in tier 1, you'd maintain a cerebral perfusion pressure between 60 to 70 millimeters of mercury, optimize sedation, ventilate to normal PaCO2, not hypocapnia, but normal capnia. Osmotherapy, which is what you were referring to about the fluids, and this is either mannitol or hypertonic sedative. We'll consider that in a second. Consider CSF drainage. Well, that's a neurosurgical technique that nobody other than a neurosurgeon would be doing that. And then consider anticonvulsants. Now, interestingly, in tier 2, which is a bit higher, they talk about mild hypocapnia, and I will cover that when we go through hyperventilation in more detail in a second. But that's where neuromuscular blockade is. So neuromuscular blockade could be either in tier 2 or tier 1. Okay, so it's like there's no consensus on that. And they say, oh, hemodynamic challenge to guide individual treatments, which is a naff way of saying, go by the hunch and see what happens when you do something to your patient, because there is no consensus. And then tier 3, which is basically a neurosurgical critical care, is barbiturate coma, mild hypothermia, and decompressive craniectomy. So that's the tier. And for us, it will be tier 0 with a bit of tier 1.
So the tier 1 is when you bring in neuromuscular blockade.
Yeah.
Is that something you would feel comfortable with us doing in austere environments?
I think so. I think if you've got the if you've got the availability of your medications and the supplies, yes, that is. I mean, it just depends on where you are. I can't give you a definitive answer because it will depend on so many variables. But let's assume you are preparing to look out for potential severe TBI. Yes, then the answer is by definition, then you must have all the basic kit to satisfy a tier 0 and tier 1. So in terms of our listeners working the pre-hospital care, In the UK, it'll be pretty easy because it'll be very quick for you to get yourself into a emergency department where these issues can be maximized. Even tier 0, tier 1. But really, getting to a neurosurgical unit is not that far in terms of geographical distance. So it depends on where you are in the world. But in austere environments, you may not have that luxury. So you may have to take top cover decisions, and this is why I wanted to consider this topic. Sometimes the time frame for evacuation or transfer to a higher level of care may not be possible for lots of reasons, and therefore you on the ground have to make with top cover backup decisions to withdraw therapy. So not just the quality of life; it's the quality of dying as well. So I don't think that there's a black and white rule. I think it's a gray area, and I think for every scenario that you can give, there will be people around the world with different opinions. But I think from a osteo condition, if you can manage tier 0 and tier 1, then I think you're doing as good as anywhere else.
So neuromuscular blocking, can you walk us through that as a paramedic? What exactly does that mean? What drugs are we using?
I think as far as a neuromuscular blockade is concerned, the reason for, if you paralyze a patient, you will not be able to assess their neurological function because they're paralyzed. Okay.
Right.
So what I'm saying is, the moment you paralyze somebody, the assumption is you've paralyzed them because they're a severe TBI. Okay, but you're not going to paralyze somebody who's had a mild to moderate concussion, but have a score above 8, because then you're going to mask cerebral irritability, you're going to mask seizures, you're going to mask the motor responses to stimulation. So it's a double-edged sword. However, if you are in a situation where you don't want somebody to cough or strain, because this also increases ICP. And as I've said to you earlier, sustained rises in ICP actually is a good prognostic factor for deterioration in neurological outcome. So I think it's a balance. There's a balance of why you're mechanically ventilating somebody. And the other thing to remember is that if you paralyze somebody for a long period of time in a severe TBI, not only do you mask the presence of seizures, but you also run the risk of developing a critical illness polyneuropathy, which is basically saying their quality of life in terms of rehabilitation is very long and very prolonged. So the outcome is bad. So the general issue is, do not use neuromuscular blockade, but in certainly a severe patient where you cannot afford them coughing or straining, that is the sort of downside versus the benefits. Do you see what I'm trying to get? So I don't think we can say do not. It'll just depend. If a patient is deteriorating, so the GCS is 8 or less,
we're going to intubate. Yeah,
go for NMB, because at the end of the day, you have to use all factors you can influence in tier 0 and tier 1 in the absence of ICP, because you don't have no idea what the ICP is. Your guess is as good as mine. So, but you're going to have to look at surrogate measures, what their vital signs are. Are they dropping the blood pressure? Are they getting a bradycardia? Are they hypertensive? Cushing's response and all these kind of things. So by paralyzing somebody, it may sound easy, but it actually needs to be done in a more judicial, sensible, evidence-based approach.
Understood. And the ocular ultrasound, the measuring of the nerve sheath, would give you an idea of increase of ICP over time.
Yeah, I think the ocular ICP measurements in people who are experienced would give you a surrogate evidence as to what is going on, and you could use that to see relief, especially if it's a prolonged field care situation. Changes in that baseline. It's not an absolute measure; it's a relative measure. So if things are improving, then in terms of the ultrasound, then you can be reasonably sure that your interventions to date are going the right way.
Use it as an indication of trending.
Yeah. A trend analysis. Yeah.
Right. So, and there's a risk of ventilator-associated pneumonia once you use neuromuscular because they're not moving. That's going to increase the risk of vape. Is that right?
Yeah, I mean, I think any patient who's on a ventilator for any period of time is going to get VAP. There is no question. Now, why it occurs, I think there's been the simplistic one where endotracheal cuff is not 100% effective. You get micro aspirations or micro channels and forming in the cuff. Gastric contents can leak through, or there might be a little bit more potent effect, and the inflammatory mediators are affecting the lungs. So I think it's really a very complex situation. The longer a patient is on a vent, mechanically ventilated, they are more likely to get a VAP.
I wonder if there's a study that shows VAP rates for austere environments versus ICU. My guess is because ICU is such a more antibiotic area that the VAP must be lower rates. Do you think?
I think it's not that simple, Aebhric, because the problem is that patients who actually get onto neurosurgical critical care are usually the people who have survived early death. So they are a different cohort of patients. Do you understand? And for us in pre-hospital care, if we get the basics right, we don't really have the data of sufficient integrity to sort of say, if you do this in pre-hospital care, this is the outcome, because there's so many
variables, right? Yeah,
variables from just from the journey of the patient.
Yeah.
So I think the reason why I want to discuss this topic is to say, do the basics right is the bottom line. Do the basics right, and things will be okay for as well as you can, given today's evidence.
So back to the ICP versus hypovolemia. Is this a good segue into what would you do with a casualty who's hypovolemic and also has increased ICP? Which one's more important?
They're both important. I think the recommended in tier 0 is having a hemoglobin of 7 is your direction point. So if your hemoglobin's lower than 7, then you would give red cells. No question about it. Okay. Now, the question is, in terms of osmotherapy, 20, 30 years ago, the military started using hypertonic saline, and especially people working in special forces, in Austrian environments, felt, oh, great, hypertonic saline is our answer. We can use it. It would carry small volumes. It's low volumes. Well, these are the days just about when IO were coming in. So there has been a sort of choice between mannitol or hypertonic sodium chloride to increase the plasma-osmotic pressure, drawing water from the ECF in the brain across the blood-brain barrier, thus increasing ICP. That was the logic. With IO, there's no worries about getting a central line. So that problem is reduced. However, what we need to know is that you only need, today's practice is to do intermittent bolusing, not just by one continuous infusion, but just intermittent bolusing. This is where monitoring comes into it. Now, the problem with either mannitol or hypertonic saline is that it has an adverse effect of hypotension and secondary brain damage. So what I'm saying is you're trying to treat one problem, but the ensuing effects or adverse effects of that intervention is actually to cause further brain damage. So if somebody has got hemorrhage from severe trauma plus a head injury, I would go for conservative fluid treatments, but making sure that the blood products, i.e. the blood components of your blood, has got a hemoglobin of at least 7 or above, 7 to 9. So at least you've got oxygen carrying capacity, and then you alter the volume status according to the CVP.
Okay, that's a helpful answer. So mannitol is a drug. I had an old SF medic tell me that the only time he would give mannitol is if he literally could see the hospital through the helicopter or through the ambulance, and then whack in the mannitol because it was it's a one-shot wonder. Is that too old school, or is there?
I think it is too old school. I think that's too simple an approach. You can't afford to see the site of a hospital to intervene for an ICP problem. Okay, so I'm talking about austere environments. You're not going to have that luxury. So you're going to have to use mannitol or hypertonic saline, whichever is available to you. You're trying to treat a multifactorial problem with multiple interventions. So it's not just the mannitol, not just the osmolar therapy, but it's also the hyperventilation, the neuromuscular blockade. You're trying to treat a lot of things at the same time.
So you mentioned hypoventilation. When I first started in the 80s, we were taught to hypoventilate, or do we even care anymore?
In those days, because that coincided with the time when I started anesthetic, it was hyperventilate on the grounds that if you hyperventilate, you wash off the PaCO2. We know that PaCO2 is the primary factor for cerebral blood flow. This is why if you hyperventilate, you feel lightheaded and you collapse on the floor. So the idea was, all right, let's hyperventilate and reduce PaCO2, but this reduces blood flow. And if you reduce blood flow, you're reducing perfusion. If you reduce perfusion, you're reducing tissue brain oxygen. So it's a double-edged sword. So the consensus for that now is to say, keep the ventilation within the normal range, 4.7 to 6 kilopascals. Because we know that if you reduce blood flow and reduce the volume to reduce ICP, there will be a contrary effect of brain ischemia. However, normocapnia is what the consensus says for all severe TBI, and mild hypocapnia, we're talking about 4.3 to 4.6 in sustained ICP. So we're not talking about those days of just hyperventilating people. We're just saying if you just can keep to the normal levels, if you see normal is 4.7 to 5 to 6. For the consensus, they say 4.7 to 5.1. And for mild hypopnea, they're talking about 4.3 to 4.6. So we're talking about really just around the lower limits for safety.
Okay. I know it is 35 millimeters of mercury to 45 millimeters of mercury. You would look at, say, 30 at the lowest.
Correct.
And go off of your ETCO2, not about your vent rate or tidal volume.
Correct.
All right.
Correct.
And what's our target for CPP? What's the magic number, Winston?
Yeah, I mean, again, this is, you're asking me really difficult questions to which I don't even have the answers. The expert consensus says a CPP, cerebral perfusion pressure, 60 to 70 millimeters of mercury. But you don't, remember, you need an ICP to allow a continuous calculation of what CPP is. Because CPP is MAP minus ICP. But if you're not measuring ICP, then you're just guessing. Now, here's the thing. If you want to increase the MAP, okay, because you're assuming that the ICP is going up, you either give extra fluid and use vasopressors. Now, that's very logical. So the idea is you do a bedside MAP challenge. You titrate your vasopressor to increase the MAP by 10% for 20 minutes, and then you see the impact on ICP and clinical assessment. Well, that's not within the remit of austere environment. No way. There's no way you can do that. However, now this is where not the paradox, but the adverse effects come in. If you use a vasopressor or fluids, you're also running the risk of organ ischemia. So you may knock off your kidneys. Mm. You may knock off your gut. You're also going to get hypoglycemia. And we know hypoglycemia, hyperglycemia are bad predictors of outcome in brain injury. Mm. And finally, if you've got a tachycardia and somebody's critically ill, especially in the elderly, a heart rate above 110, you're putting the myocardium under strain because it's been perfused in diastole, and you don't have that chance in diastole for coronary perfusion. And the other evidence is that if you have a positive fluid balance over 24 hours in a severe TBI, it's associated with a higher ICU mortality.
So we need to measure urine output and the fluid in.
Yeah, and CVP and stuff. And really, I think the message that I want people to take home is neurocritical care management is probably the most critical situation where you need to get the basics right. The ventilation, the head up position, the sedation, the analgesia, enough fluids to get a urine output, preventing them from coughing and bucking. So really it's attention to detail. And remember, in the environment we're talking about, you're single-handed often. And you haven't got a multidisciplinary neurocritical care unit to back you up. So you're going to have to make some pretty much. So I would rather our listeners get tier 0 and tier 1 and do it well, say to themselves professionally, yeah, that's the best under the Seattle consensus guidelines that I could have done for my patient. Because remember, there's a big risk of assuming that just because you got somebody who's got a sign of life at the ED is not necessarily a success.
It's what they exit with. Yeah.
It's their final outcome when they leave, or if they leave hospital. And I think that's what I try and get my pre-hospital people to talk about. How many successful transfers have you done? They say, well, I've done quite a number, only one died. And I just think, well, have you done a follow-up of those patients? When did they leave hospital? What quality of life? And even on the best neurocritical units, the prognosis, and certainly in the severe TBIs, quality of life is reduced by 50%.
Wow.
So it's not simple, but in this age of uncertainty, if you do the basics right, I don't think anyone can be criticized.
Yeah. Do the basics well. That should be tattooed on everyone's chest.
Agree.
Yeah. So, Winston, I've got a good idea, Ferry, way out there in left field question for you.
Yeah.
CSF drainage. I remember reading a discussion on using something like an IO needle on a temporal drain pre-hospital. Is that just out there? What about draining the CSF? I mean, that's what has to happen, doesn't it?
Yes, but I would temper it with saying that it should only be done by a neurosurgeon, who by definition will not be in your environment. Because first of all, putting an external ventricular drain, which is what it is really, it is a huge risk of bleeding and infection.
Yeah.
So I put that in only so that people can realize what neurosurgeons can do. Now, if you look at Afghanistan, I don't think there was any general surgeon who put in an extraventricular drain in. It's just not something that a general surgeon or a trauma surgeon would do on a daily basis. There may have been one, in desperate cases where you've got CT scans, evidence of brain damage, and you've got a last ditch effort. But clinically, I don't think it's for us in pre-hospital care.
Fair enough. So, what is your advice on this period? We're waiting for consensus. We have historical references of how to treat and assess ICP. What's your advice to the medic working in an austere clinic?
I think that my advice for anyone looking after severe TBI is to do tier 0, tier 1 well. Okay? So in other words, the basics well. And keep everything within normal vital signs, knowing that every intervention you do, be aware of the downside of that intervention. So if you're mechanically ventilating somebody, they'll be paralyzed, and therefore you will mask seizures and you will mask motor signs for the GCS. So it's sometimes people think, oh, that's fantastic. The patient's not moving, they're comfortable. But neuromuscular blockade is recommended, but not for the reasons we think. So take a personalized approach. Do you know what the cause of the TBI, severe TBI is? Do you know the time course? Do you know how long you were since the initial injury? Do you have an institutional or national or societal algorithm? And if you have one of your own, follow it, because there is no evidence that any one particular algorithm is superior. So that's the good news. So stick to what your license allows you to do. Secondly, use the lowest possible therapeutic interventions to control the situation of cerebral perfusion pressure, which implies ICP, using the tiered system. So if you can just master tier 0 and tier 1, you'll be backed by the expertise consensus from Seattle in 2019. So that is basically the bottom line. Keep it simple, stick to the basics, but do it well.
That's fantastic advice that would be applicable to pretty much everything in medicine, Winston.
Correct. I think so. I think so. And I think we need to make sure that our graduate students, undergrad and postgrad, are aware that 99% of the time it is really doing the basics well, and it's only occasionally where some dramatic intervention may alter the outcome dramatically. So doing the basics well, just on a long-term professional lifespan, if you can get the basics well and understand what the principles and the algorithms are based on and what the limitations are, because that's what we've discussed today, the limitations. 30 years ago, when I started anesthetic training, nobody told me about the downside of hyperventilation. Nobody told me about the risks associated with hyperoxia. Nobody told me that it was important to keep the hemoglobin to at least 7, but ideally 9, not necessarily normal hemoglobin levels, but at least 9. But if you've got blood products, transfuse. And keeping the fluid, keeping the CVP within normal limits, keeping the carbon dioxide within normal limits. Enough oxygen just to maintain a saturation of SpO2 of 94%. It is, I could repeat this dogma for nearly every critical care situation, but there'll be a little nuances where they differ. And remember, if the brain gets inflamed, those are the messengers that start knocking off the other organs in the body. The brain is not on its own. We know that in any organ dysfunction, any organ failure, there is a pattern of organ dysfunctions that follow. And in the austere environment where there's delay, the brain is not the only thing to be considered in a severe TBI. Preserving other organs, heart,
big 3,
is just as important. So going back to what I said initially, severe TBI is a distracting injury, just like in severe burns.
Okay. Thanks for that, Winston. And we'll see you again next month.
Okay, thank you.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, Corum, Corum.org.